TMA doesn't mean too much adrenaline.
Okay.
At the end of the session, you'll be able to understand the difficulty of thrombotic microangiopathy diagnosis by clinical or laboratory tests. You'll be able to discuss the different types of thrombotic microangiopathies, and you'll be able to outline a simple pathway to diagnose and treat adult thrombotic microangiopathies. So that's the plan. Common clinical expressions of TMA, you're aware of TTP, of course, and HUS and DIC are all thrombotic microangiopathies. In other words, they all produce the same pathology if you were to look at a tissue under a microscope in these processes, but they are different pathophysiologic processes. The original TTP case report occurred in 1925 and was by Eli Muskowitz, but the actual sort of definition for TTP occurred in 1966, and that was two people, Amorosino Altman, and they actually said if you had, which is thrombocytopenia, hemolytic anemia, fever, neurologic signs, and kidney failure, then you had the pentad and you had TTP. Unfortunately, this diagnosis in terms of the pentad was often elicited at the time of death because the disease had progressed significantly. In 1955, Gasser and colleagues described 5 children who had thrombotic anemia, meaning a low platelet count, hemolytic anemia, and kidney failure. And this new diagnosis was called hemolytic uremic syndrome, which has evolved over time, initially called diarrheal HUS, HUS to typical HUS. And you can see this diagram shows a glomerulus of a kidney, and inside that glomerulus are red cells and platelets. The platelets have aggregated, and the red cells, you can see, are misshapen or fragmented or hemolyzing. So that's sort of the in vivo picture. So what about HUS? It's predominantly seen in children, except in outbreaks. About 90% are secondary to E. coli 015787. And there's about 10% or less than 10% are called atypical HUS or primary HUS. And there are many genetic variants, but the majority have uncontrolled complement activation as the mechanism causing this abnormality. So what about secondary TTP and HUS? So we talked about the primary forms. What about the secondary forms? They really represent what's called the quiet majority. In the largest study, that's by Fujimura's group in Japan, 919 cases, about 55% of TMAs were secondary to another disease process. In the Oklahoma registry, about 62%. In our own registry at our own hospital, about 46% were secondary. A small percentage may have Adams 13 inhibitor or genetic complement abnormalities, but the vast majority don't, unlike acquired TTP, in which the majority have the inhibitor to Adams TS13. So we have these names: TTP, HUS, STEC HUS, atypical HUS, secondary TTP and HUS, hereditary TTP. But without effective therapy, the need to differentiate has really been academic. But then came an effective treatment. All patients with TTP died until 1959, when Rubenstein described an 11-year-old girl who received exchange transfusion who had TTP and did survive. Bukowski in 1977 described 2 patients who he actually carried out plasma exchange on, and those patients survived, and Byrne in the same time period did plasma infusion to a patient with TTP who also survived. So that this really spawned a study which was carried out by the Canadian Apheresis Group. And this study wanted to see whether plasma infusion or plasma exchange, which was superior in treating patients with TTP. The study was published in the New England Journal in 1991, and it was really a randomized controlled trial, and it showed that patients who received plasma infusion had a 78% survival rate, whereas those who received plasma infusion only a 63% survival rate. So there was significant superiority for plasma exchange versus plasma infusion. So it would appear that we were adding something, which you do with plasma infusion, but also with plasma exchange, we were removing something as well. The question is, we didn't really know at that time what we were adding or what we were removing. But the race was really on, because TTP mortality occurs in days, really, and rapid diagnosis to provide plasma exchange to prevent mortality became the standard. And this was spurred, obviously, by the CAG's original description in 1991, and also Bell's series in 1991, published in the New England Journal, and Scully in 2008, all saying that you have significant mortality if you wait. You must treat as soon as you have the diagnosis of pentad. In fact, Scully suggests that patients should receive plasma exchange within 4 to 8 hours of presenting with thrombocytopenia, hemolytic anemia, which is unexplained, with a normal INR and PTT. That's sort of the differentiator. So that became the dawn of the dyad, as we pointed out: unexplained thrombocytopenia, hemolytic anemia, normal INR and PTT equals plasma exchange. Actually, there was a potential mechanism described earlier by Moak in 1982, and he suggested that it's possible, because he was looking at patients who relapsed with TTP, that they had their, when you have a blood vessel injured, it releases that, see that spiral in the diagram? It releases von Willebrand factor multimer. And it's this factor actually has binding sites on it. And if it extends, it opens those sites, and platelets actually overcome their charge repulsion and stick to the von Willebrand factor multimers. And normally, Adams TS13 is an enzyme which is also closely associated with von Willebrand factor multimer, and it cleaves this multimer, so it localizes the thrombosis just to the area of injury. But you can understand, if you didn't have functional Adams TS13, you'd become a systemic clot. In other words, you would become a very active case of TTP. It wasn't until 1998 that this mechanism was confirmed, and this is by Sy and Liane in Brooklyn and Furlan in France. And they both described in the same journal, in the New England Journal in 1998, that patients have inhibitors who have TTP against Adams TS13, the enzyme that cleaves that multimer. And also, Furlan showed that people with HUS don't have that enzyme. And so we now knew that plasma exchange, why it worked. It removes the inhibitor, and interesting enough, plasma contains Adams TS13, the protease, and it replaces it. So that's what plasma exchange does. So this was really the moment of great discovery. It led to an attempt to define all DIC TMAs as having a severe antibody-mediated deficiency of Adams TS13 activity. So that sounded great. The only problem is that when this was tested, we found that only 33% of 142 clinically diagnosed TTP cases who responded to plasma exchange, all of them responded to plasma exchange, only a third of them had severe Adams TS13 deficiency. So what's the problem? Well, the problem is, much like the Dion quintuplets, is it's difficult to differentiate in the adult TTP from HUS. The major reason for the evolution to TMA rather than TTP-HUS in adults is because you can't confidently differentiate at onset TTP from HUS in the person who's standing in front of you. You can have a rough idea in terms of the way they present, but it's not 100%. In fact, 20 to 60% of TTP patients present with kidney damage, just like HUS people. And up to 30% of TTP people have diarrhea, just like the diarrheal HUS people. And interesting enough, in terms of HUS, up to 78% of people with HUS have preceding neurologic symptoms. So you can see there's a great clinical overlap. Clinically, you have a spectrum of HUS to TTP, primary forms and secondary forms to disease or clinical context. And so we have to make a tentative diagnosis of TMA or TTP-HUS to start treatment immediately, because we have a patient with unexplained thrombocytopenia, Coombs negative hemolytic anemia, normal INR and PTT. You can see the platelet thrombi on the bottom at the left, the fragmented red cells in the middle, meaning that they have a microangiopathic hemolytic anemia, and you can see the glomeruli with microthrombosis and fragmented red cells. So this is really thrombotic microangiopathy, where you can see you have primary forms and secondary forms. So we have lots of forms of TMA to deal with clinically, and unfortunately look the same. In terms of the treatment for primary and secondary TMA, we treat all TMAs initially as if they have TTP. We treat them with plasma exchange, and the survival rate is somewhere between 60 and 90%. The only patients who really don't respond to this initial approach are those with malignant hypertension, those who've received mitomycin C therapy, those who have had a stem cell transplant, those who have a disseminated malignancy, and those who have STEC HUS. Those patients don't respond well. Even your atypical HUS people, about 50% of them will respond. So what about treatment for STEC HUS? Well, the majority respond to volume repletion. There is a meta-analysis and also a study from Germany which says there may be benefit in more severe cases to receive plasma exchange. There's a new treatment for STEC HUS, which is called eculizumab, which is a very expensive monoclonal antibody. Costs about $750,000 a year. This was used by Annie Lepérec at St. Justine in Montreal to treat 3 cases of severe neurologic involvement with HUS. And these patients got better. And generally speaking, when you get severe neurologic involvement with HUS, it's usually a pre-terminal event. So it was quite impressive. In the outbreak in Germany, it was used quite frequently. Initially, it looked like a great response. But later, largest report really suggested really no benefit with the eculizumab over plasma exchange or conservative therapy. So what about atypical HUS? It occurs equally in children and adults. Only a minority, less than probably 15%, have complement depression in terms of simple complement parameters. But almost all patients, at least 2/3, have recognized abnormalities in complement regulation, so that things that normally inhibit the complement pathway are often inactivated. So people are actively sort of activating their complement, and this is attacking their blood vessels, and they're secondarily creating thrombocytosis or thrombosis in those vessels. There's a new treatment for atypical HUS, and this has been shown to be eculizumab, this very expensive monoclonal antibody, which blocks complement. There's 2 studies that have been recently reported in the journal which show very favorable responses for people with this extremely rare disorder. So the conclusions are the inhibition of thrombotic microangiopathy by plasma exchange or plasma infusion was decreased by 88% in trial 1 and 100% in trial 2. So there's a significant time-dependent improvement in renal function in patients with progressing and long-duration thrombotic microangiopathy. And eculizumab was well tolerated. So what about atypical HUS? Early mortality of TTP, complexity, timing, and cost of both the genetic testing and eculizumab itself, and the fact that less than 5% of adult TMAs are at risk, and half of those respond to plasma exchange. We generally just do simple complement testing at outset. The majority are rejected as primary TMA with normal Adams TS13 who fail to respond to plasma exchange. So really it's a failure to respond that makes this diagnosis. So timing is critical, and best guess at present is failure to respond to plasma exchange at 4 to 5 treatments with Adams TS13 greater than 10%, Shiga toxin negative, and no secondary causes. What about refractory and relapsing TTP? So of those TTP cases, so if we're to look at a general population that comes towards us, about 40 to 50% will have TTP. And 30 to 50% of them will actually be refractory, which means they respond and then relapse very early, or they respond and they relapse within a month. And complete response means they're asymptomatic, they have platelets are greater than 150,000, their LDH is less than 25% above normal. We stop the plasma exchange in 24 hours. If they relapse in 1 to 30 days or have a transient response, we say they have a refractory TTP. If they relapse in greater than 30 days, we say they have a relapsing TTP. So what about refractory and relapsing? We treat patients with plasma exchange and steroids, and we now treat them with rituximab. A recent study we were involved with at 40 patients with relapsing refractory TTP showed that 100% of relapsing and 85% of refractory cases that respond to a course of rituximab therapy. Anecdotally, splenectomy is successful for those who are rituximab and cyclophosphamide resistant, but they are rare. The majority of people will respond to rituximab. If they don't, and as I say, the vast majority respond to plasma exchange, but those 30 to 40% who are refractory or relapsing, we add rituximab, and the majority of them don't recur again, although a small minority will. And a very small number won't respond, and then we get into the issue of splenectomy and alkylating agents to actually treat them. In terms of splenectomy, we obviously use plasma exchange to prepare people for this surgery if it's deemed absolutely necessary. So the optimal treatment for primary and secondary TMA is plasma. And in fact, more plasma is better than less. The CAG study done by Rock in the New England Journal showed plasma exchange was superior to plasma infusion. The plasma exchange patients also received substantially more plasma than the plasma infusion patients. George Nguyen et al. Showed that twice daily plasma exchange was effective for refractory patients with TTP. We looked at our own patients and showed that those who received larger daily plasma volumes had better outcomes with TTP than those who received lesser volumes of plasma. And we also had a very dramatic case of a patient with very severe TTP who was over 70, presented in a coma, platelet count less than 8,000, greater than 800, and was totally unresponsive. And within 2 days of continuous plasma exchange, everything returned to normal. And he left the hospital about 5 days later and had no recurrence. So it may seem difficult to diagnose the type of TMA in adults. And there's a new simple pathway to diagnosing the type of TMA in adults based on treatment response and lab tests. The problem with lab tests are that with genetic testing for atypical HUS, that takes up to 3 months, and a third of patients will be normal. In terms of Adams TS13, at our center, we can get that within 24 to 48 hours, but most centers in this country, it takes weeks to get the answer. So in our pathway, you have the initial diagnosis for a patient who has unexplained thrombocytopenia and hemolytic anemia, in which they have a low hemoglobin, elevated LDH, a normal INR and PTT. We investigate them, and so obviously in everyone we get their CBC, their LDH, their blood smear. We look at haptoglobin, which is an enzyme that confirms whether they're hemolyzing. We look at Adams TS13, which is the enzyme which seems pivotal in the diagnosis of acquired TTP, and its inhibitor. We do blood cultures to rule out sepsis and secondary DIC. We look at stools for Shiga toxin in terms of STEC-HUS and E. coli 15787. We look at an antiphospholipid antibody screen, since people with antiphospholipid antibodies can look exactly like TTP if they have catastrophic antiphospholipid antibody syndrome, and they need to be treated differently. We look at their ANA and C3, C4, CH50, and we do the Coombs test to try to exclude other secondary causes for this TTP, as well as hepatitis B and C. If we suspect atypical HUS, we'll order genetic testing, but it's expensive and takes a long period of time. So initially, with the patient, we treat them with 75 mL per kilogram of cryosupernatant plasma. That is plasma in which the von Willebrand factor multimers have been removed, so it's less likely to promote their thrombotic microangiopathy. However, if they have chronic obstructive lung disease, asthma, or are allergic to solvent detergent-treated plasma, or allergic to cryosupernatant plasma, we then give them solvent detergent-treated plasma. We also give them methylprednisolone and antihistamines. We give them, obviously use an anticoagulant, which is called acid citrate dextrose, ACD, in a ratio of about 1 in 15 to make sure their vessels don't clot when their blood is being put through the plasma exchange machine. And we also give calcium gluconate supplementation, since acid citrate dextrose binds calcium and lowers it. That's how it creates its antiplatelet action. So in terms of the evolution of therapy, you get plasma exchange for 1 to 2 days. And by then, we'll have your Adams TS13. If your Adams TS13 is less than 10%, your inhibitor is greater than 50%, we're looking at the left-hand side of the chart, then we continue plasma exchange and you respond. Your platelet count will be 150,000 LDA, which will be less than 25%. The average time is usually 9 to 11 plasma exchanges. However, about 30 to 40% of these people will go that middle diagram and become refractory or relapsing. And we have to look at treating them. We'll do that on the next page. But those who have Adams TS13, which is greater than 10%, some of them will be refractory or relapsing, TTP, but some of them will respond, and in fact, to therapy, even though their Adams TS13 is normal, and in fact, they'll go into complete remission. However, if there's no response with the patient, in other words, if their platelet count does not rise and their LDH does not decline, after 5 exchanges, we'll start eculizumab therapy and test them for atypical HUS. So this is a phase 2 study evaluating the efficacy of rituximab in the management of patients that relapse and refractory TTP, which has just been submitted to Kidney International and hopefully should be published shortly. And what we showed is that if you take these refractory patients and relapsing TMAs, the relapsing patients, if you give them rituximab, all of them went into remission, regardless of their Adams TS13 status. Whereas the refractory patients, those who are Adams TS13 less than 10%, inhibitor greater than 50%, those were the sickest patients, interestingly enough. And those are the patients that died in our study, a small number. And we think in hindsight that we probably should have gone on to splenectomy following the rituximab because they didn't respond to rituximab, but their antibody levels were still high, their inhibitor levels are high, and their Adams TS13 was still low. Whereas the last 20, 17 of the 20 did respond with a rise in their Adams TS13 levels to normal, and their inhibitor went into the normal range. And they responded and recovered renal function. However, if they had a response or no response, didn't matter, but the kidneys didn't recover, then they likely had atypical HUS, which is a small number. We had 2 patients like that. So really what we're concluding with, and I hope I haven't confused you too much, is that in knowledge, TMA constitutes primary and secondary forms of TTP and HUS plus DIC. But wisdom is plasma exchange treatment in minutes, 2 hours, but the accurate diagnosis may be days to months. So in 2014, the clinical approach for TMA is to treat with plasma exchange and steroids. The majority will respond in 5 to 11 plasma exchanges, regardless of their Adams TS13 status. If they have no response, meaning their platelet count does not rise, and their LDH does not decline over 5 days of aggressive therapy, with increasing volumes and frequency of exchange, and they have an Adams TS13 that's greater than 10%, and they're sugar toxin negative, they have no obvious secondary cause, then we presume they have atypical HUS, we start eculizumab therapy, and do genetic testing. If they relapse in 1 to 30 days of those who have responded, we say they're refractory, and then we will start them again with plasma exchange and add in rituximab and give them 4 treatments of rituximab, 4 weekly treatments of rituximab, and if they're relapsing, 100% will respond regardless of their Adams TS13 status. However, that's in the refractory group, if it's Adams TS13 is normal and the kidney function does not recover, which is a small number, probably 2 of 20 of these patients, around 10%, then they probably have atypical HUS. They should be tested and provided with that therapy. In terms of relapse greater than 30 days, all respond to rituximab in conjunction with plasma exchange and steroids. So that's the good news. In terms of disclosures, obviously I've received speaking honoraria, received grants. Obviously you're involved in the Kidney Foundation grant. Thank you very much for that. And I serve on the advisory board of the Canadian Apheresis Group. I co-chair the Kidney Foundation of Canada's Biomedical Research Committee, and I'm also the president-elect of the World Apheresis Association. So those are my disclosures. I'm sure there are lots more questions than answers. But I just wanted to give you some food for thought about the complexity of making an accurate diagnosis, how you have a simple treatment plan to deal with these complexities, so the vast majority of people will get a good result who present to plasma exchange centers with unexplained thrombocytopenia, with a hemolytic anemia, and a normal INR and PTT. Thanks for listening.